Orofacial myofunctional disorders, DX, RX, TX, and PX. We created this so you can show not just yourself and your patients, but also your colleagues what you are looking for in your assessment. These are 32 clinical markers of the phenotypes of an orofacial myofunctional disorder. Mouth breathing. When the nose is congested or occluded, mouth breathing is obligatory. However, often the habit of oral breathing is present even after the nasal breathing has been restored. After. Identification of insufficient nasal breathing and proper referrals are made. Behavioral modification techniques and functional retraining is implemented to change the mouth breathing habit and promote lip-together, proper nasal breathing. Untreated. Mouth breathing is meant to be an emergency situation. When it's chronic, a long face develops with undesirable changes to the maxilla, jaw, nose, mouth, neck, and shoulders. Mouth breathing is linked to gum disease, sleep disorders, temporomandibular joint dysfunction, behavioral issues in children, forward head posture, and more. 2. Open mouth posture. Before. The habit continues to encourage abnormal growth and development and may lead to orthodontic problems, TMD, perioral skin conditions, dry and cracked lips, narrow palate, nail and finger skin infections, etc. Attention must be paid to underlying physiological, psychological disorders, and behavioral problems. After ruling out allergies, nasal obstruction, and muscle low tone, OMT therapists will modify the behavior of the patient to promote lip seal, including normalizing the breathing if the patient is a mouth breather. Untreated. If the cause of the open mouth posture is not corrected, the patient may develop a forward head posture, atypical swallowing, long face syndrome, lack of negative pressure, or a vacuum seal on the tongue and the palate, and a narrowing of the palate. Malocclusion and OSA may also be present. 3. Anterior tongue thrust. Before. Lack of nasal breathing or sleep-disordered breathing may lead to the tongue moving or resting forward and pushing against the teeth when static. During the swallow, instead of pushing up into the palate, the tongue moves forward and laterally, called anterior, bilateral, unilateral, or bimaxillary tongue thrust. After ruling out allergies, nasal obstruction, and muscle low tone, myofunctional therapists will modify the behavior of the patient to promote a lip seal, including normalizing the breathing if the patient is a mouth breather. Untreated. If the cause of the open mouth posture is not corrected, the patient may develop a forward head posture, atypical swallow, a long face syndrome, lack of negative pressure or vacuum seal on the tongue and the palate, and a narrowing of the palate. Malocclusion and OSA may also be present. 4. Bilateral tongue thrust. Lack of nasal breathing or sleep-disordered breathing may lead to the tongue moving or resting forward and pushing against the teeth. During the swallow, instead of pushing up into the palate, the tongue moves forward or laterally, called anterior, bilateral, unilateral, or bimaxillary tongue thrust. Forward static tongue rest position may also lead to abnormal development of the palate. After ruling out allergies, nasal obstruction, and muscle low tone, myofunctional therapists will modify the behavior of the patient to promote a lip seal, including normalizing the breathing if the patient is a mouth breather. Untreated is the same as the previous 2. Tongue tie. Embryological remnant of tissue or aponeurosis of the genioglossus muscle in the midline of the undersurface of the tongue and the floor of the mouth that restricts tongue movement. Ankyloglossia is a severely restricted tongue tie. After. The myofunctional therapist has been trained to assess the tongue and develop normal tongue functions. If there's a restricted lingual frenum or a tongue tie, the myofunctional therapist will refer the patient to the proper doctor who will release the restriction surgically and then, with therapy, repattern the tongue muscles to assure maximum benefit of function from the procedure. Untreated. If the tongue is not able to function normally, the growth and development of the stomatognathic system is also compromised. This may affect digestion, speech, breathing, dental occlusion, TMJ function, posture, sleep-disordered breathing, and chronic pain patterns of the head and neck. Lip tie, also called a restricted labial or buccal frenum, is an embryologic remnant of tissue, also called midline deficiency, which may restrict normal lip function. The myofunctional therapist has been trained to develop a lip seal and habituate proper function of the orbicularis oris muscle and perioral muscles. If the patient presents with a lip tie after attempts to stretch the tissues are unsuccessful, normal functions are restricted and the therapist will refer the patient to have the restriction removed. Following the procedure, the therapist will repattern the muscles and functions. Untreated. An untreated short upper lip may create an open mouth at rest position where malocclusion and periodontal disease are more likely to develop. Atypical swallow. Before. Although there's a range of normalcy in the swallowing pattern, usually swallowing with a tongue thrust, either forward or lateral, with lips open, and unstable jaw stabilized by tongue and facial muscles is considered to be atypical, which is a mild degree of swallowing disorder. After. By identifying and correcting breathing patterns, by repositioning the tongue at rest, by repatterning the swallowing mechanism, and by applying behavior modification techniques, myofunctional therapy is able to correct and normalize atypical swallowing. Untreated. Atypical swallowing is the result of smaller but significant dysfunctions. Lips are open, jaw instability, tongue thrust, that by themselves or together may contribute to larger issues such as malocclusion, TMD, facial pain, and more. 8. Habits. Before. Habits are tongue, lip, pacifier, and thumb sucking, leaning on one's hand, nail biting, lip licking, facial mannerisms, excessive movements, etc. Sometimes, if the infants are not allowed sufficient time or use an incorrect sucking technique, they may find satisfaction in sucking their fingers or pacifiers or objects or their tongue. Intensity, frequency, and duration of the habit will affect tongue rest posture, mastication, TMD, lip health, facial skin, and more. After. The myofunctional therapist is trained to apply self-awareness and behavior modification techniques to eliminate the habit and to optimize oral function. The therapist uses prizes and rewards and follows the success in children for 30 days while the family is coached on how to achieve long-term success. Untreated. The habit continues to encourage abnormal growth and development and may lead to orthodontic problems, TMJD, perioral skin conditions, dry and cracked lips, narrow palate, nail and finger skin infections, etc. Attention must be paid to underlying physiologic, psychological, or behavioral problems. 9. Chewing disorders. Chewing disorders are chewing with the mouth open, excessive chewing of gum, exclusive chewing on one side, avoidance of foods with certain textures, such as meat, raw vegetables, seeds, some fruit and nuts, preference for soft or pureed foods, pain or discomfort during chewing, or abnormal jaw movements. After. Chewing is treated by activating and equilibrating the chewing muscles, by reducing or eliminating excessive chewing, by making the patient aware of habits, by optimizing the length and efficiency of chewing, and by collaborating with other professionals at normalizing nasal breathing and dental occlusion. Untreated. Chewing relies on proper nasal breathing, occlusion, and jaw movement. A disorder of these three conditions, or an open mouth habit, create compensatory functions that in the long run may create TMJ disorders and negatively affect the digestive system. 10. Facial muscle dysfunction, or parafunctions, include lips open at rest, use of facial muscles to stabilize the mandible during swallowing, mannerisms such as puckering, pressing, shifting, excessive muscle tension, tension of the neck muscles, wrinkling of the forehead, periocular muscles, and furrowing of facial muscles. These usually accompany a tongue thrust swallow. After. Myofunctional therapy provides self-awareness, behavioral modification, relaxation techniques, and optimization of chewing, swallowing, rest posture of the lips, tongue, and jaw to significantly reduce and eliminate facial parafunctions. Untreated. Frequency, duration, and intensity of facial muscle dysfunctions or parafunctions will be the deciding factors in developing facial and TMJ pain, malocclusion, swallowing discomfort, shoulder and neck pain, or voice changes due to the involvement of the neck and shoulder muscles. Tongue thrust, saliva pooling, dental plaque, drooling, facial muscles are also possible outcomes. 11. Hypotonic masseters. Before. The masseters are both chewing muscles and postural muscles to keep the jaw in place during activities such as walking, running, or jumping. The masseters are designed to crush food between the teeth, so when the teeth are in malocclusion and do not touch, the masseters are deactivated. In severe cases, they lose mass and the ability to chew or to support the mandible, with the mouth hanging open. Weak masseters are often present in TMJ disorders. After. By using flexible tubes or wafers, masseters can be retrained to chew properly and to assist the tongue and lips in providing the proper jaw posture at rest. However, in the case of significant malocclusion, an orthodontic intervention may be necessary before myofunctional therapy. Untreated. The proper position of the jaw at rest is very important for the health of the TMJ, and its position depends in part by the activation of the masseters. Weak masseters also impact dental occlusion, chewing, swallowing, and the function of the temporalis muscles, which become hypertonic and painful. Speech misarticulations. Before. When the tongue stays low in the mandible at rest and thrust during swallow and the nasal breathing is not optimal, then speech misarticulations, often called lisps, develop or persist. The sound S is produced like a th with the tongue between the teeth, which is incorrect in the English language. Other problems are an excessive protrusion of the tongue for the L, TH sound, lateral lisp for the S sound and Z sounds, insufficient or delayed development of the R sound. After. Speech pathologists are able to identify the origin of the misarticulations. Anatomical tongue tie, physiologic lack of proper nasal breathing, or neurologic dyspraxia or apraxia may provide adequate treatment. Other professionals can optimize oral functions or eliminate dysfunctions that accompany misarticulations. The speech misarticulations are more of a social issue and the symptom of a more significant orofacial dysfunction, such as ineffective nasal breathing, tongue thrusting, open mouth posture, etc. Ignoring the underlying causes of orofacial dysfunctions that present themselves with lisps may contribute to changes in craniofacial growth and development, malocclusion, and more. Tonsils and adenoids. Tonsils and adenoids are part of the immune system. Adenoids are situated in the posterior portion of the nose. Enlarged tonsils and adenoids reduce or prevent nasal breathing, impact the proper function of the soft palate and middle ear, and may cause sleep-disordered breathing. After, enlarged tonsils and adenoids are to be suspected when there's an open mouth posture, tongue thrust, painful swallowing, nasal voice, and other possible signs. A referral to an ENT is recommended, as enlarged tonsils and adenoids, which are not visible from the mouth, are a medical condition that need to be addressed medically when left untreated. Enlarged tonsils may lead to chronic open mouth posture, mouth breathing, bad breath, sleep-disordered breathing, tongue thrust, dental malocclusion, and some degrees of craniofacial anomalies. Enlarged or hypertrophic adenoids may also contribute to sleep disorders, poor nasal breathing, chronic open mouth posture, changes in voice resonance, sounding too nasal, ear infections, and symptoms and degrees of craniofacial anomalies. 14. TMD. When the orofacial muscle function and patterns are incorrect, the symmetry, equilibration, and range of motion of the TM joint may be dysfunctional, causing discomfort or pain. After. Repatterning the muscle functions and creating awareness of habits that may interfere with proper jaw function may decrease or eliminate discomfort and dysfunction. Untreated, pain patterns and improper habits may increase. The patient may continue attempting to compensate for the dysfunction in order to relieve the pain. Often the patient will develop medication dependency, psychological problems, referred pain to neck, shoulders, and back, and general sensitization. 15. Sleep disorders. These include snoring, sleep apnea, narcolepsy, circadian rhythm sleep disorders, insomnia, night terrors, nightmares, sleepwalking, sleep talking, bedwetting, sleep-related movement disorders, excessive daytime sleepiness disorders. After. Myofunctional therapy may be an aid to assisting sleep medicine physicians and sleep dentists attain a patent airway and educating patients as to the value of exercising muscles of the stomatognathous system. We can also reinforce the sleep physician's or dentist treatment plan and motivate the patient to continue treatment. Untreated. A patient's condition may worsen, especially if they ignore the physician or the dentist's treatment plan. Sleep disorders are linked to malocclusion, TMD, obesity, digestive problems, diabetes, worsening of periodontal disease, behavioral problems and learning delays in children, accidents, injuries, and even death in severe cases. 16. Bruxism and clenching. Clenching is closing the teeth tightly, often for prolonged periods of time. It is a normal function when bearing down, as in weightlifting or in constipation, but the habit of clenching damages the teeth and the temporomandibular articulation, causing chewing muscle dysfunction and pain. Bruxism is grinding of the teeth, usually at nighttime, and it's a sign of sleep-disordered breathing. After. Myofunctional therapy provides awareness of the habit to the person who clenches and helps them identify the connections between stress and clenching. As a stress management parafunction, provides strategies to reduce or eliminate clenching. Identify some symptoms of disordered nasal breathing, which is often the main contributor to bruxism, or other symptoms of OSA, and make the appropriate referral. Untreated. Clenching is a natural response to stress, but both prolonged stress and clenching have been well documented to have widespread effect on the orofacial muscles and the mandibular and dental functions. Bruxism underlies sleep disorders for which an appropriate assessment is needed. Bruxism also causes teeth damage, changes in occlusion, muscle pain, temporomandibular pain, or discomfort. Low tongue rest position. Anytime the nasal breathing is impaired, temporarily or chronically, the jaw drops and the tongue positions itself low and forward to open up the upper airway. A low tongue rest posture can also be present without nasal involvement, with the tongue not being positioned against the palate. After. Since most dysfunctions of the mouth have an origin in the nose, myofunctional therapists recognize that low tongue rest posture is the symptom of something more important, like lack of nasal breathing. In the absence of nasal obstructions or neurological disorders or conditions, myofunctional therapists may retrain the brain in changing the low position habit by repositioning the tongue at rest and by promoting lip seal. Untreated. Both low tongue rest posture and its underlying causes have long-term effects involving the TMJ health and function, stability of the dental occlusion, possible narrowing of the maxilla, or possible chronic open mouth posture. 18. Snoring. Snoring occurs when the air flows past relaxed tissues in the throat, causing the tissues to vibrate as one breathes, which creates irritating sounds. The irregular airflow may be caused by a passageway blockage and may influence the soft palate and uvula to collapse. After. Myofunctional therapists are able to identify signs and symptoms of snoring and sleep-disordered breathing, of which snoring is one, by using sequential exercises to develop the proper tongue rest position and swallowing, activating the palatoglossus and genioglossus muscles, developing a lip seal and normalizing the breathing, the patient's snoring frequency and intensity will reduce. Untreated, snoring frequency and intensity may increase, leading to OSA and family problems. Oral sleep appliances and/or surgery may be recommended by sleep specialists to increase the airway space, such as UPPP or orthodontic surgery. 19. Malocclusion. Malocclusion is the inability of the teeth to interlock properly during chewing and swallowing. Engel's classification of malocclusion looks at the relationship of the maxillary and mandibular teeth. After. Myofunctional therapists may promote proper oral rest posture, tongue resting against the palate, lip seal, normalized nasal breathing, correct the muscular freeway space, and eliminate oral habits. However, the timing of intervention is crucial. A young child may have the occlusion naturally normalized, while a grown adult may require orthodontic treatment in order to correct it. Untreated, without addressing the underlying muscle dysfunctions, orthodontic relapse is possible. Other problems related to severe untreated malocclusion are insufficient nasal breathing, OSA, TMD, orofacial pain, periodontal disease, aesthetic problems, self-image issues, and digestive issues. Further information about this project and scientific references with a detailed bibliography, please visit us at www.aomtinfo.org/OMD Matrix.